This conference will now be recorded.
Annalie, the floor is yours.
Good morning. I'm really very glad to welcome all of you, not only from Europe, but across the globe, attending this very interesting and important workshop, which is about cybersecurity and healthcare. But before we go to the actual topic of the workshop, I would just like to introduce you the HubIT project. Today, digital technologies play an increasingly important role in our society, and they really have a very huge potential in offering solutions for societal challenges related to health, energy, environment, and all other fields. At the same time, when we all as citizens benefit from an increasing number of digital technologies, there are also several concerns that are related to their uptake. I think it's quite natural that people start asking questions. What about our privacy, security, and ethics of ICT and all other technologies that surround us daily? Furthermore, what are the societal implications and what is the impact of digitalization on our society and fundamental values? Furthermore, how will the future look like? Is it realistic that artificial intelligence and robots take over? Is my nurse in the future also a robot? And regarding healthcare, which data are collected, how they are stored, who has access to them, who owns them, and many more. So how we as citizens and humans should live in a changed world. So it makes it really evident that we need to consider ethical, legal, and socioeconomic aspects of ICT, meaning that before launching a new product or digital service, we should engage citizens and analyze the societal impact of our product or service. Just an example from another field. If you seed a plant, you become responsible for it. And most probably, you are also eager to learn how various conditions affect the growth of your plant. But if this is not about a single plant, but there is a whole garden where different plants grow together, you also need to know how companions help each other to grow and what does it take to make your garden a healthy and beautiful one. So this is what brings us closer to the HubIT project which Civita Estonia has been coordinating together with 14 partners from 10 countries for the past 3.5 years. So what we are doing, we are promoting responsible research and innovation in ICT that considers the values, needs, and also expectations of society. So it sounds really nice, but what does it mean in practice? It means actually that before speeding up with an ICT innovation or research idea, we believe that it would be really beneficial if ICT sector would work together with citizens and also social sciences and humanities experts who can give really interesting ideas how to solve the real life problems what people have. So how have we done that? We have organized a series of events, almost 40 events across Europe, by bringing together ICT sector and social sciences and humanities experts. And what really makes us happy is that people really confirm that this type of events, they are kickstarters of a collaboration. And it's not only about bringing together people. As I mentioned earlier, it is about promoting a responsible research and innovation. It might be that it sounds a little bit abstract at first, but in practice, it really has several measurable indicators. So these are gender balance, ethics, which is one of the main concerns of people. Also, it means scientific results being public and open to everyone. It also has an interesting dimension, which is called science education, meaning that the results of our projects should be available and people should understand that what we are working with. Last but not least, it also means RRI governance structures. They should be in place in our organizations and projects. So, HubIT project has been here to make a difference. And what are our results? We have created a beautiful platform which we have called or renamed as HubIT Metropolis. It really has several very useful resources which we all can use in our everyday practice. We have collected a number of projects and actors. There is a database of ICT and SSH related actors and projects which everyone can make use of. We have identified key challenges. What are those challenges, real-life challenges, which we should solve? So if you are interested, you can take a look. Also, we have brought together so many people across Europe, and therefore we have developed also a matchmaking tool, and there is a pool of experts who are interested in this cross-sectorial collaboration. So you can go and you can take a look. Also, to understand that what is our current standpoint, our partners have developed a very useful assessment toolbox. So again, to measure how far we are with implementing responsible research and innovation, there is a toolbox which we all can use. Last but not least, if you think that this is an interesting approach and you would like to promote ICT and social sciences and humanities express collaboration, you would like to make use of those beautiful tools which I just presented, we are really asking you to contact us and act as an ambassador of HubIT project. I thank you all for listening, and I wish you a wonderful and insightful workshop on behalf of the consortium of HubIT. Thank you very much once again, and enjoy the day.
Thank you very much, Annalie, for that introduction to the project. Now, a little introduction to the topic that we will be discussing today. Let me just share my screen. Good. I hope you can see my screen. If not, give me a shout. The topic of cybersecurity within healthcare is an extremely important topic. You're dealing with sensitive personal data. You're dealing with vulnerable people. From an ethical point of view, any problems with that is very high up in the scale of problems. It's not the same like hacking an ordinary company. If something happens and data is compromised or equipment is compromised, it's a whole different ballgame. The aim of this workshop is to see what the current status is of cybersecurity within healthcare, to see what vulnerabilities there are, to see what still needs to be worked upon, and to possibly come up with solutions that should be taken into account going forward. We have 3 keynote speakers. Let me just do my slides. We have 3 keynote speakers. The first one is Ms. Victoria Hart. She comes from the angle of social sciences. She is a social worker. She works within the healthcare industry. She will introduce herself before she starts speaking, but she's got the social perspective of this topic. We then have Professor Ron Kennett, who is an expert in data mining, and he will be talking about adversarial artificial intelligence, and he'll introduce himself as well. And then we have Ms. Annette, whoops, sorry, my screen's gone, Annette, and she will be, she's a cybersecurity expert, and she will be talking from the IT cybersecurity point of view, give her opinion. And then afterwards, we will have a roundtable with the keynote speakers where we can have a discussion, discuss what they have all talked about, and then see what we can, as a group together, maybe come up with. So just a few words before Victoria takes over. Just a few basic things that easily found on the internet. Cybersecurity's Ventures is an organization that has predicted that in 2021, the healthcare industry will suffer 2 to 3 times more cyber attacks than the other industries. That this is an expanding security threat, particularly now with COVID as well, and everything going online, a lot of healthcare going online in countries that maybe haven't had that in the past. It's become vulnerable and it's become an easy target. So that's a scary statistic. From the cost point of view, the cost of a data breach is huge. This is also a point that needs to be addressed. It's not an ethical issue, but it is a financial repercussion of these things. And also all the protection of all the systems is a huge amount of money as well. They're expecting to spend about $125 billion on security from 2020 to 2025 in order to protect as much as possible. I myself am not under any illusion that anything is completely secure, but certainly to do as much as can possibly be done to help systems and to make sure they're okay. Basically, what organizations in the security industry are saying is that there needs to be a layered approach to protect. It seems to be that human error is a major issue. And in fact, 95% of breaches to date are caused by human error, are caused by people, for example, clicking things that they shouldn't, and their home computers becoming infected with a virus. And then when they log into the healthcare system, they are importing the virus into the healthcare system, for example. So organizations have to invest in strong infrastructure with endpoint detection and response. And there should be a system information event platform that monitors everything to make sure everything is okay. And finally, need a mobile device management platform that has proper inbuilt security, not the freeware that is available, which is easily hacked. That's really all I want to say, apart from the final point that there are many vulnerabilities within IT technologies. We know that it is a priority for organizations, particularly within the healthcare industry, to make sure that these vulnerabilities are nipped in the bud as much as possible. But unfortunately, it is known in the industries that within 2021, it's no longer that if there'll be a security breach, it's when and how to minimize it and how to make sure that, that things aren't escalated. That's just a little bit background. Now I'm going to pass you on to Victoria. As I said, Victoria is from the social work side. So Victoria, if you take over. You're now the presenter, Victoria. If you just put your camera and sound on, please.
Yeah, hi. Sorry, just getting the slide up and running. So yeah, just as an introduction, I know Dana just mentioned, so my name is Victoria Hart. I'm a social worker. I've been working in health and social care, particularly in mental health, for about 20 years. And for all that time, I have had an interest. I did my master's dissertation 20 years ago about the use of technology in healthcare, and obviously I've seen so many developments over the way. This is a very short presentation, you'd be pleased to know, and it's going to be attempt just to bring to life some of the points that we see at a ground level that impact the people who use the technology, and some of the challenges and issues that come up. As will be clear, I'm not coming from the technical perspective, but really thinking from a user perspective. And so, yeah, just running through some of those issues. I'm also not going to be presenting answers, but I guess from that humanities point of view, that social sciences point of view, posing lots of questions. And it's really themes that I'd like to be taken away. So to start with, I mean, I talked about looking at technology from a user perspective. And in this context, I'm seeing this user through these three lenses. That's the user as the patient, or the service user, as we sometimes call in social care. The user as the professional, and that might be, you know, a non-technical professional. It might be a registered profession like a doctor or a nurse. It could be a care worker as well. And then the other perspective, which I think it's useful to engage with when considering some of these real life issues, are the carers and the family members, the informal carers, we like to say non-paid carers and family members. And just a bit of my work background, because I think that helps place this within a context. So I've worked with people with learning or intellectual disabilities in the past, with physical disabilities, with mental health issues, and that's where I am at the moment. But I also spent a large part of my career working with older adults, and particularly people with dementia. And so that's some of the focus of some of the issues that I'm going to talk about. It's about the use of technology, perhaps where people might have cognitive impairments. But back to putting users at the heart, I think it's also really important to remember that these three roles, it's why I use the Venn diagram, aren't unique. And that people can cross over and be professionals and patients, professionals and informal carers. All of these things can coexist because we don't fit neatly into boxes, or rather into circles. I shouldn't try jokes. So I'm going to look at some real life examples, and I'm looking at these examples with these four themes in the background all the time. So the overarching themes which have been mentioned around privacy, around transparency, and by transparency I mean, does the person using or being engaged with the technology know what it's for and what's being done with that technology? Reliability, you know, when things break, and involvement, of how involved have the people who are the end users through those three lenses been in developing and understanding the development of the technology. But all of this is overarched by that professional ethic, by the issues around professional ethics. And I think that, and they can produce challenges in terms of some of the ethical questions that we ask. So the first example I'm giving is around some of the GPS trackers. And I've been involved with some of these, using these in my previous job, you know, when we've used GPS trackers for people with dementia, and it might be a concerned family member who wants to check if someone close to them gets lost or is unable to find their way to safety. And it can be a fantastic use of technology, and actually in practice I've literally seen this save lives. But there can be a concern around the loss of the integrity of the person. So some of the questions, and it doesn't mean this can't be used, but some of the questions when we worked within the service was, is this use for the family member's reassurance, or is it for the benefit of the person for whom it's being used? And is there a risk perhaps of paternalism in assuming family members will always want the best interest of the person for whom they are caring? There are aspects, obviously, of saving money and saving time, but what might be the potential risks or questions. And yes, you know, as I say, real big benefits. This could and has meant somebody maybe staying in a home that they love rather than needing to move into residential care or having much more restrictive care. And then there's also what is the type of tracker used. I'll have some examples in a minute, but they can take all different forms. And are they easily removable, for example? That was always a difficulty we had. You know, what if they take off the strap? Where is the data going and who has access to it? And in terms of reliability, what risk is there of the technology failing? Can we rely on it, either software or hardware? So, you know, some examples. So, for example, the watch, and I think that's, you know, I have a watch at the moment. I'm not wearing it now, but I have a watch with GPS on it. And I think perhaps as we grow older, it will become something we're more accustomed to. It could be minimal. This article I saw was about the use of GPS insoles that can be used, and I guess, and actually that's one of the things that we used in the service where I worked. But one of the issues that we were raised with is, how do you get consent for that? And it can be very easy, but could it be used covertly, and how do you build some of those issues in? And this last one, it's just an advert that I saw, and this is actually, I haven't got a picture of the device, but it's one that fits in the pocket. And the thing that kind of troubled me when I looked at this advert was, how was the person who is the user put at the heart of it? So this advert came with a headline, "Built to locate what you value." And as you can see, some of the examples were pets, vehicles, even kids. You know, there's an issue there, but with the older person, it's written as dementia wandering. And this might seem quite minor, but it does said to me something about how these are sold, and are they sold to meet the fears of the family rather than preserving the integrity and the humanity of the person who is using them. I mean, there have been a number of studies specifically around some of the ethical issues. One of the key findings, it was a paper in 2012, White and Montgomery. I can provide the details later, but it did show that generally there was for the people that used these, which was both the carers and the individuals, when they were able to give their feedback, was that they did prefer safety over privacy. And so, you know, but it is something that I think we need to ask ourselves as these things are being developed, have these things in mind, so that we don't end up with stigmatizing adverts which talk about a loved one as an object and dementia wandering as what we're solving. And in terms of that, it was about the involvement. Who designs and builds these units? How are the people who use them involved? And the next group of examples is around assistive robots, and there's massive variation. This is a really broad term, so the context of which I'm talking is about these robots that might help with specific tasks or be used for social interactions. And there has been research, and I think I've got just a little strap line here to show about how beneficial some of these use of these robots can be, and they can certainly save money in terms of some of the tasks that are involved. And one of the examples, this is Stevie. And this Stevie, I took this photo from an article in Time magazine in October 2019, and there was a special edition about technology in healthcare, and it was looking at the use of Stevie in a care home. And I'll just read the quotation from the article, because I think it explains it much better than my own words would, to be honest. So the voice command, "Hey Stevie," activates the robot, similar to how the wake word Alexa activates Amazon's Home Assistant. Stevie responds to other words with speech, gesture, and head movements. Tell the robot you're sick, for example, and it slumps forward with a sorrowful frown on its LED screen face and says, "I'm sorry to hear that." Pay Stevie a compliment, and the screen reverts to a smile. When at rest, it tilts its head gently and its digital brown eyes blink, patiently waiting for the next command. So the team that worked on this, they used this as in real. They looked at research in real time as how it was being used in the care home, and they reported that the residents did ask Stevie to do things for them, but actually they became quite sad when Stevie left them. So Stevie would come and do something and bring something back, but they liked spending time with Stevie. Stevie can sing, Stevie can tell jokes, and while Stevie can elicit empathy, Stevie doesn't express empathy. I mean, the blinking eyes is programmed into Stevie. And another example, this is a really kind of long-standing example, is Paro the seal. I've got a picture of Paro there. Hopefully you can see, which has had a really positive impact in so many trials and provides companionship. Again, I've seen this used to really good effect in residential care, but again, elicits empathy without expressing it. And some of the questions that we must ask is, what happens when Stevie breaks? What happens when Paro breaks? What happens when they can't function anymore? And what is it that they're actually replacing? Are they replacing human contact, or are they augmenting it? Is it that the contact that they have is more reliable? But on that transparency level, what do the people who use Stevie and Paro know about them? And what choices are they able to make about investing emotional energy in building relationships with robots? And who's involved in the development? And I'm not saying it doesn't happen, I'm sure it does, but it's useful to know about how people have given feedback about these robots, and what do these robots then learn about us. The next examples, this is a really, really large category, and I'm pushing a lot of things into one, but it's about, motion detectors, trackers, falls detection. That Fitbit probably shouldn't be there under that, I just realised, but CCTV cameras, and that could overlap with robots. But I did want to look at it separately because it relates to a lot of more broadly than that. And again, I've seen this used in really great effect in practice. Falls detectors, the fall detector in the middle can be a lifesavers. There's an example here, but there's so many different types. They can link to cameras. I used to work with a woman in London. I'm based in London, and her daughter lived in South Africa and could know where her mum was in the house. It gave her reassurance, and it actually meant that her mother stayed at home much longer than she might otherwise have been. But again, thinking about where does the data go and who uses it, as well as how reliant we might become on this data, it can lead to potential challenges. Are we giving people the information about where that data is being stored? Are we tying people into contracts with specific companies? And as I say, I'm not saying that this is necessarily means that they can't be done, but just all things to think about and how clear that is. And also, are people aware of privacy legislation in terms of these issues? And how involved are people who might use these services in the development of them? And it might not be the person today who's able to be as involved, but it might be the person who needs it tomorrow. And just as an example again of this is just this one example of an advert that I found, and this is a CCTV monitor type thing, and it's the advertising again presenting this as a solution for the family. The family will know what's up. But it does beg the question of the involvement of the person who is being monitored. I'm not saying that this is a bad thing, but always thinking, who is the device for? And this looks like a great product. But if we look at some of the information that's being shared, are there long or frequent bathroom visits? Is there increased pacing? Is the person going out at unexpected hours? And all of these might be information that somebody would have concern sharing. And the focus is very much about the family rather than, and is it replacing human contact? And I want to be clear, I'm very much in favour of the use of technologies in this area, but I think we always need to bring ourselves back to what the focus is when thinking of the person at the heart of receiving care. At what points do they become involved in the development, and having it, and again, does it tie into contracts? Are people aware of those things? And is this about a solution for the safety of the individual or the reassurance of the family member? Now, it can be both. It can be either, absolutely legitimately, but it's important that these are issues that are considered. Just moving on, I've just put this up. This is some guidance on the CQC, which is the regulator of health and social care in England. And they do actually have guidance both for family members and for providers about the use of covert and overt CCTV, because this is an area that's increasingly been a challenge. The last area I want to cover is slightly different, but it's just a general, you know, discussion about the electronic records. I mean, I've worked with electronic records for as long as they've been around, from remembering when we actually had to scan all our paper records into the brand new electronic record system. They've evolved enormously. And obviously they're not going anywhere. Really, really important. It means I can work from home, from my work computer. I can get onto networks, secure networks, working with healthcare information, you know, through all of that. Makes it so much easier. But do I know what's happening to that information? And I'll just this is a really simple example, but in January, I work in a hospital, and I had my COVID injection in January. I didn't think twice about it. It was through work. But then, and I can connect to my care records, my personal care records, on an app on my phone. And I was looking at that, and I saw that information was there on my GP records. And I'm sure I must have agreed to it at some point for that information sharing between occupational health and GP, but I can't for the life of me remember giving that consent. And I mean, I'm not, as I say, that's my issue, but just, you know, sometimes ticking these boxes. Another issue is when somebody's in the UK and has requested a COVID test, particularly, you know, towards the end of last year. I think they're changing now, but you had to go through a credit check. You know, it asked you about a credit check in order to verify your identity, and you know, I clicked yes because, you know, I want the test, but it's not always clear about how and why where this information is going. But back to the electronic records at work, as Dana said earlier, you know, these records, software and hardware can fail, and these are just some examples. Like, you know, you can pull them off so quickly, but two of them are about external failures, and one of them is actually about that email that got sent to 800,000 accounts and jammed up the system. And often, having worked in these systems, staff can use and do use workarounds, to be honest, in terms of some of the privacy issues, because how do you get that information quickly? And if the system isn't designed for you to find it, you know, staff will make their own. Just before I finish, I'm just coming back to involvement. I've talked about it all the way through, but I think it's just such a key point of thinking always, when we start and we're looking at some of this technology, how we identify who the user is. And as I say, those different layers of users, and often there will be multiple users, and how do we engage with them and think about what they actually want and how they are able to verbalize what they need and help with the design, and also telling people what happens when things goes wrong. So finally, just to wrap up, obviously, you know, absolutely in favour. You know, it can be raising some of the concerns, but absolutely in favour. I've seen massive changes for the benefit in terms of what these systems can do, and there are countless opportunities, but ethical practice isn't an add-on. It needs to be there from the start, and we need to make sure that we ask the people who are using this, and, you know, I include myself, what people want, and ensure we're clear who the users are. We need to be clear about telling people who use the products what to expect from them, whose problem we're solving, and how they've helped to input into identifying the problems that need to be solved. And also how we explain what happens when things get wrong, and that things do go wrong, and build contingencies into what we do. So thank you very much, and that's that's me.
Dana, we cannot hear you.
Yeah, number one of online talking is unmute yourself. What I was saying is thank you, Victoria. That was really, really, really interesting. And I wish you were sitting next to me, Michael being next to me, and you could have heard his comments as you were speaking. Really, really interesting. And it's brought up a lot of questions and a lot of potential discussion that we will have in the roundtable later on. Okay, our next speaker is Professor Ron Kennett, and we're delighted that he has agreed to be part of this conference. We really are quite honoured to have him here. I will now pass over the floor to Professor Kennett, and having seen his slides in advance, this is going to be really interesting. So Ron, you are now the presenter. If you could please unmute yourself and share your camera.
Thank you, Dana. Thank you, Victoria, for the warm up. Your talk is just in time. You don't see my slides, do you?
I see your slides. I do not see you.
Okay. So we can handle that problem.
Very good. You're good to go now.
Okay. So I'm coming from a more technical perspective. I'm a statistician, and the business of statistics is to turn numbers into information. And so what I'm going to talk about is coming from that angle. You can see the slide, right? You're okay?
Yes, all good.
Okay, thanks. So I've written 14 books over quite a few years. I wear several hats. One is chairman of the KPA Group, which is a company I founded and was probably the first Israeli company to join projects in the midst of FP4. This is 1998 when Israel joined the European Framework Program, and this is due to the initiative of Dana's father. So I'm sort of closing the loop here. We've been partners in 8 European projects, and it's always been interesting. I think this has given us a tremendous boost in the things we are doing. I'm also a professor in Turin, in Italy. I'm now also, for the last 3 years, at the Samuel Neyman Institute for National Policy Research at the Technion in Israel. And since 6 months, I chair the Data Science Society in the Association of Engineers in Israel. The topic is related to a book I edited a couple of years ago called Statistical Methods in Healthcare. And in that book, we deal with individuals, we deal with patients, we deal with hospitals and healthcare systems. This is an edited book with different chapters. And in today's talk, I'm going to give an overview of healthcare. It's going to repeat some of what Dana said in the beginning. An overview of what has happened in healthcare in terms of cyber attacks. You will probably remember that. The role of sensors, and this relates to Victoria's talk. And then we move into analytics, which is taking the numbers produced by the sensors. And so I'll mention the artificial intelligence. And then the talk is about adversarial AI, but as you see, it's only one bullet in the list of bullets. I'll handle an issue of alarm fatigue that we worked on, and then I'll mention another area, which is home hospitalization, which opens up lots of questions and opportunities. And the future outlook is designed as a kickstart to the panel discussion at the end. Another book that you don't see here, which I will mention in the last slide, is dealing with information quality. And what I liked about Victoria's talk is that all these devices she was referring to are actually generating information in some way. To assess the quality of the information requires some clarification on the goal. And this came out very nicely in her talk. So for goal 1, what you have is fantastic. For goal 2, can be problematic. In that book, we have a framework for handling an assessment of information quality. But that's not the topic of my talk here. So healthcare, yes, we are talking about. Okay, did something happen? Yeah.
No, it's fine.
Okay, I'm trying to shrink the. Okay, now I'm good. So lots of hospitals are with digital healthcare initiatives. 16,000 was a report of IBM. Lots of data is unstructured, which means text, which means images. And a patient is really a number generating system, 1,000 readings per second. This was in 2015. The slides have links, so people interested in more information on what I'm showing, can get access to that through the links. Deloitte, a few months ago, talked about the digital health ecosystem, and they emphasized the role of artificial intelligence, robotics. We heard about assistive robotics, sensors. We also heard about that. Blockchain systems, natural language processing, Internet of medical things. This is in contrast to Internet of things. So these are specific things, and cloud computing solutions. Another aspect that is becoming an issue is interoperability. You want these various systems to be able to share information, and in the sharing of information, you also open up issues related to privacy. So we are talking about predictive and preventive care. We are talking about cheaper, precise, and less invasive treatment. And we are responding to what people expect. This is an update on the IBM report I was referring to before. Yet another update. This is not too long ago, end of October 2020. Hospitals are being attacked. These are cyber attacks for ransom money. So these are not just attacks for fun. These are attacks with severe consequences. The data, what can be done with that data, if someone is able to get the data from the hospital. This has raised in a very concrete way the impact of what Deloitte was saying. Okay, now we have AI, we have all these systems. So initially we're talking about the access to data. We have all this data, all these sensors generating data. Now we have all these systems. Okay, now we also have cyber attacks. So the issue can be very serious. Imagine what happens to a hospital that cannot operate, and the advice was not to give in, because it gives the attacker more motivation to keep doing that. So, okay, what you do? You're a hospital, your systems seem to be hacked, you're not working. The advice you get is not to give in. Actually, a lot of the hospitals did give in. So we're talking about sensors. Now we have sensors of sensors. Okay, we worked with a startup company called Atlas Sense. In one sensor, they can pick up blood pressure. They can track falls, ECG, all sorts of signals, and this is now putting some challenge on both the analytic part, but also on the healthcare part. What do you do with all these numbers? Unless they really turn into useful information, does it mean that you can do better things, or does it mean that you can do things in a cheaper way, or does it mean you can do things in a more reliable way? We have all sorts of situations where the vast amount of numbers that are being produced did not necessarily translate into better care. So sensors are number generators. I don't even call them data, because in many cases people have all these numbers stored in, and they don't really know what to do with them. Data is numbers with a context. So if you know something about the patient, you know what type of bed he has, you know what type of conditions he's in, then the fall detecting device can be interpreted, and then it changes from numbers to data. So data, numbers with a context. And sensors, so here I have an example. You know, you see someone running, okay, this looks like sports, but in fact it's generating numbers. So these devices are producing the numbers we talked about. So in that setup, what we are seeing now are things that are sort of rocket science type of things. So this is Ran Balitzer. He's in charge of the research and innovation center at the Clalit healthcare system in Israel, which has about 3.5 million people with 15 hospitals and general practitioners throughout the country. So he says, yes, this is a quote. You know, picture this. Instead of going to a physician, so you're not doing anything, your doctor calls in. So the doctor is proactive with some bad news. Within 6 hours, you're going to have a heart attack. So why don't you come into the clinic and we can fix that? So the proactive approach is also combined with some prescriptive approach. So it's not just sounding an alarm, it's also providing some kind of resolution to the issue. Because this is now prevention healthcare, you know, at its best, if you think about that. So in analytics, all these numbers, all this data, we turn the data into information. We distinguish between analytics that is designed for monitoring giving us this early warning something is going to happen. We have analytics that aims at diagnostics. Why? If we want to treat it, we need to have an idea of why this happened. Prognostics, what's going to be the implication? If the implication is very serious, then this is what this call was about. You need to come now. If the implication is you don't have to worry about it, let's do another check in 5 years, that's different. And prescriptive is tell me what to do, what should be done. So AI is helping provide these 4 types of analytic solutions. But now we enter a new era, and AI has evolved significantly, and people started asking questions. Okay, now you are taking these MRI pictures. Okay, you are running these deep neural network algorithms, and you give me a diagnostic of an epileptic condition, and you even tell me this is done with high confidence, 85%. And I'm the treating doctor. I need to understand why. Just the fact that you give me this number, even though I trust it, is not enough. So this opened the door to what is now called explainable AI. So we have an X in front of the A, and several initiatives are in that direction. We want to explain what is going on. Microsoft has a huge project called Inner Eye. I have the link up there. I wanted to show you a video, but I won't do it. It's up to you to look into it. We now can replace the visual inspection of the expert with some machine learning algorithms, which is actually doing a very good job, but we are still 1 step remote from the caregiver who also has to interpret and make decisions. One of the aspects we talked about cyber attacks that this is raising is the ease in which these algorithms can be manipulated. So we have these systems. This is a famous example. We have a panda picture. We have an AI algorithm that can recognize the panda as a panda with 57.7% confidence. We introduce some noise. This is what you see in the middle. And now the algorithm is telling us this is not a panda, this is a gibbon, and we are very sure of that. Just to make sure that you know what a gibbon is, it doesn't look like a panda. It looks similar, but it's not. Now imagine a diagnostic recommendation of the system which takes you to the gibbon when in fact it's a panda, and the implication of treatment that this would entail. So we're now facing some issues, and this is called adversarial AI. Another example, also quite famous, is this parrot, which is with some manipulation turned into what the algorithm classified as a bookcase. How can a bookcase be similar to a parrot? No, we can't tell, but that's what happens in the algorithmic space. Another famous example of adversarial AI is this effort to distinguish between a dog, a husky, and a wolf. So many pictures were shown. The algorithm was trained, and it got very high accuracy, 90% accuracy. And then things started emerging. The picture with the red X was misclassified. What turned out is that the wolf was usually the picture of the wolf in the context of a snowy environment. So what the algorithm was actually picking up is the white aspect of the snow. And the implication was not understood. So it did correctly classify the wolf as a wolf, but not for the reasons people imagined. And now this opens up all sorts of issues. So these classifiers, they have their limitations, and people can actually manipulate these. So this is one of the papers on that. It's a relatively recent paper showing that with very small changes that you cannot identify with a naked eye, the deep neural network, the black box algorithm of AI, can be fooled. So these perturbations are very subtle, but imagine what can be done if someone wants to cyber attack an organization and create chaotic situations. They won't even know that something happened. Okay, I said I would go into a very interesting topic, which is alarm fatigue. That also is linked to Victoria's talk. I guess we can talk about these things in the panel. Now we have all these systems. If you click on the link, you'll hear the actual sound of that. And people know that this is a big issue. Alarm fatigue is a very serious threat. The way it's been handled is with questionnaires. There is a paper on that I show here, or with some assessments. So you have here an Excel spreadsheet that is used for running such assessments. So you go, you talk to people, you look into what happens in the intensive care. You look at the signal that is coming from a specific device. You assess the alarm load, the impact from a medical perspective of the alarm. Okay, this is a spreadsheet that is from the ECRI handbook, the alarm safety workbook that is promoting that. And now we're getting data. Okay, so here is part of a spreadsheet that is driven from a rather qualitative assessment of a situation in a hospital. What we can do is start analyzing this data. This is an example of a Bayesian network where the variables that you have tracked are linked in a cause and effect type of relationship. So the harm and the risk are on the right. You have the different types of effects that qualify the alarm. And one of the things these networks can help you achieve is first diagnostic. I can condition the network on the high risk and severe harm events, and I can profile where are they coming from. This is taking you from the effect to the cause, or it can be predictive, telling me, okay, what's going to happen in a certain part of the hospital. What should I expect in terms of impact of the alarm systems that are installed there. So both arrows should lead to some kind of rethinking of what is going on and improvement. This is very serious. This issue of alarm fatigue. Victoria talked about human error. So you could relate it to human error. The alarm fatigue topic is related to human error, but there are things that could be done, should be done, that are on what is really behind this overload of alarms. So here's another paper that links into that. So now we also have data, lots of data, and there are data regulation efforts. HIPAA is the most famous one. This has been around for quite a few years now. It is legislation that provides data privacy and security provisions for safeguarding medical information. It is enforced in the US by the Office of Civil Rights. In Europe, you have the GDPR guidelines that are law. Then you have a more recent high-tech health information technology for economic and clinical health initiative, ARRA. It's the American Recovery and Reinvestment Act, and it's applying. It's applied to health information technology. So there are data regulation efforts. Usually, the regulation is not preceding the threats. It's just addressing past threats. So there is some kind of lag in the regulation and what is going on. So Victoria also mentioned the health records, electronic health records. Obviously, that's a key to lots of improvements that we can have. I heard Obama say that if you are a dog in the US and you live in California, but you get moved to Florida, then the health records are following you, and the treating veterinarian in Florida will know what happened to you. But if you are an individual, if you are a person, no such thing. So, okay, electronic health records, lots of potential. Things are being developed. The regulation on data, which I just mentioned, is in some cases hampering effects and the potential impact of these electronic health records, because they are not shared. They are, and then okay, so what's the right balance? The final point in my talk is something that is looked at as the future in healthcare, and that's home hospitalization. So you know, we have people, they go to the hospital, but maybe they can stay home and get treated at home. That will require lots of data, because now the treating physician is going to treat 20 patients from the hospital. He needs to have access to their condition. That means he has to see the data. We had in Israel an example of that with COVID in the ultra-Orthodox communities, where the numbers of treated patients seemed low at some stage. Now they are very high, but at some stage they seemed low. And then an investigative reporter for the television found out that they are treating people at home with ventilating equipment, and this is sort of under the hood type of thing. So home hospitalization is something that poses a lot of questions. and will require high-level monitoring and will require lots of data. So my final slide is an overview of what I've tried to present here. And I'm taking a perspective based on quality. In the 1800s, 1700s, quality was considered from the product perspective. In Amsterdam, you have the Guild of Drapers sampling the drapes and putting their seal. Okay, a lot of the pharma industry is still operating that. You know, they are sampling the tablets. Then in the 1900s, the focus started shifting to process. One of the advances on that was the control chart. This is due to Walter Shewhart, 1912. He proposed the control chart to track a process. Then we moved to service quality. So service, being an abstract process, also requires some management. And that led to management quality. So now we are higher on the abstraction. What you see at the bottom is the Juran trilogy, which tracks a process and identifies three initiatives: improving the design, pushing for an improvement process, and setting up a control scheme. In healthcare, we started seeing a big role for risk management, the Swiss cheese model of reasons, which said, okay, when something happens, you know, we have all these slices that are supposed to stop the thing from happening. If the sequence of things took us through the holes, then the event actually materialized. The book, To Err is Human, launched a lot of initiatives to improve healthcare. One of them is an initiative which was called the National Demonstration Project in the US, 1987. A book came out of that called Curing Healthcare. And now we are in the age of information. So what these initiatives we're looking at has to be reassessed. Now we have a lot of data. And what should come out as a key issue to consider is the information generated from this data. The framework that we have developed, that I mentioned before in the book, has 8 dimensions. For the goal at stake, the goal we have in mind, do we have the right data resolution, the right data structure, the right data integration? Do we have temporal relevance? So on each of these topics, I can give a 1-hour talk. The book I mentioned is addressing that. We have chapters on information quality in healthcare, information quality in official statistics in different domains. We are now talking about bioconvergence, and this is the convergence of healthcare, biotech, and technology. And this is also where these issues of ethics and privacy come up. So I'm done, and I look forward to the panel. This is weird because I don't even know if anyone listened to me.
Thank you very much, Ron. That was very, very interesting. Now I'd like to introduce Ms. Annette Madinator, who is our cybersecurity within healthcare expert, to give her sides and her perspective on what's going on. Let me just make you the presenter. And you should now be able to share your screen.
Yes, thank you, Dana. Thank you. Welcome, everyone. I believe you are supposed to see my screen now. Can you see my screen with the presentation?
Yes, you just need to make it bigger, make the presented. But yeah, can see your screen.
Yeah, how about now?
Perfect. Perfect.
Okay, right. So, yes, first of all, thank you for this opportunity. Let me be frank and straightforward. I don't really have that many opportunities to listen to non-cyber people talking about cyber issues or cyber related issues, especially when they come from such an important industrial area or area like healthcare. So for me, it's really an experience opportunity or learning opportunity. Also, the previous two speakers mentioned a lot of issues that I would like to comment on from cybersecurity perspective. And I know that I should need to introduce myself, but and I will do that in a couple of sentences. But I believe that the topic is much more important than my role in cybersecurity. Nevertheless, just a couple of sentences. I come from cybersecurity and cyber defense. I have more than 15 years of experience in this domain. Let's go back. And I know, because I have experience in the public domain, so national administrations and multinational organizations, but also in the private domain, industry service providers, and so on and so forth. And I like this angle of my own career path because it enables me to have quite a complex view. The company that I represent now is a knowledge-based company. We usually have these state-of-the-art projects and state-of-the-art processes with which we support our clients who are solely critical infrastructure, critical information infrastructure, national administration and multinational organizations, and obviously the kind of mixture of any of these potentially. And the past 1.5 years with the COVID situation has brought a lot of changes which have been accelerated very much solely because of introducing a massive home officing to the IT security or even IT service providing industries in general. So this is where we start from. Additionally, what I wanted to mention, though it was somehow mentioned by both speakers who were prior to me, is actually that hospitals are getting smart, which means that hospitals are actually fast forwarding their own digitalization through using those kind of digital devices and IoT devices that are sort of new to the industry from the perspective that we are still in a pioneering phase. Their use is there, that's okay, but the security of how to use this is just not that developed, I believe. Additionally, if we want to get to the to what I really aim to talk about is the threat landscape that affects these hospitals that we are talking about. Threat landscape is basically the summary of those potential attacks and attack vectors that us cybersecurity experts need to take into consideration. So basically, these are the bunch of those most important attack vectors that need to be taken into consideration when we somehow want to map the potential security needs, cybersecurity needs of a hospital or any kind of health service provider. And this particular threat landscape that we need to take into consideration has changed fundamentally through introducing IoT devices to healthcare in general, and all those other healthcare systems that have become accessible from remote. This access from remote comes from two sources or two reasons. One is that healthcare operators may operate, they do operate hundreds of hospitals simultaneously from a remote location. That's one reason. And the other one is, and this is simple service providing, nothing special, okay? So this is how it works. This is a functional issue, a basic functional issue. The second one that needs to be mentioned at this point is basically what we call COVID effect, which means that formerly, let's say, air-gapped systems. Air-gap means that a system is hermetically closed from the access of other systems. So it's like a one-on-one system. So these formerly air-gap systems have been made accessible from remote over the internet. What's the reason for that? It's also very simple. It comes to how to provide services from remote due to the COVID situation, which introduced this massive home officing that I already mentioned, is that system administrators have to be able to work from their homes, from their home offices. And that means that comes to a very, let's say, simple consequence. All those systems that used to be let's say, strongly monitored from security perspective and which we considered secure because accessing them was very difficult from remote, is now like this. Very easy comparing to how the situation was before. So this sort of combined situation leads us to something else, and the threat landscape that I mentioned previously has a new feature on it, which means that the attacks that we have to handle somehow are hybrid now, which means that these are a new combination, a novel combination of smart human remote insiders and automated tools. So basically the new most important threat landscape item, let's say, we have to deal with is the smart human remote insider. There may be several motivations. Some of them were already mentioned here. One is very simple and, let's say, usual in the cybersecurity scene, is to gain financial resources. That is usually a kind of single or coordinated ransomware attack. This is already well known to many healthcare service providers, so I'm not going into details about it. But it's purely for financial gain. The second one that we usually highlight is service disruption. When the aim is that the service, that the healthcare service that is provided should be disrupted somehow. And there's a third angle or third area that needs to be taken into consideration is something more severe. This is what we call terrorism. Which aims to disrupt, for example, low-level radiation devices that may actually result in death of certain patients who are treated with those particular low-level radiation devices. Additionally, what we understand from the threat landscape and the analysis of the cyber attacks, which so I'm not going into more details about how these are, because perhaps what is more important is that these attacks, let's call them attacks simply, may be going on within the healthcare systems unrevealed, let's say undetected for almost a year per system, which means that there is a bug, or there are many bugs in the healthcare IT systems undetected for almost a year. So this is where we start from, and I have to admit something. While listening to the fellow presenters, I slightly modified my slide deck so the numbering will not match. Apologies for that, but I didn't want to redo the numbering. I wanted to, so I got the inspiration to show you some pictures. In approximately 5 years ago, not 6 years ago, 5-6 years ago, I had the chance to participate at a huge cybersecurity conference, a strategic one in the Middle East, and that was actually the first time when I saw and heard a cybersecurity strategist to talk about data in this context that is presented on the slide, that data has become a new, let's say, natural resource. Natural is obviously an exaggeration, because data cannot be natural. It's a virtual thing. When we call it, let's say, a natural resource, we mean that it's available in such a vast amount, like, for example, oil, or even more. Obviously, due to human nature and human drives, what comes in the limelight is to, if it is a natural resource that we can gain access to, then the next point is that we can extract it, we can refine it, we can distribute it, and consequently we can monetize it. Okay, so that was the situation 5 years ago. Things happen, and this is where we are now. When we talk about data, what comes to everyone's mind, actually, who deals with cybersecurity, is that data have become the greatest risk ever. So the approach what we have towards data has changed fundamentally. Let's talk about cybersecurity risks themselves in the healthcare industry. Many of these were already mentioned, so I'm just running through this slide. Human error is one of the most important ones. It may be unintentional, but also the insider threat, the smart remote insider, is perhaps the most important issue we will have to tackle in the upcoming very near future. The other one, the next one, is about ransomware, which is very much related, or almost solely related, to gain financial advantages. So it's quite simple from understanding its motivation perspective. Endpoint security have already been mentioned quite well, so I'm not going into details about it. What have not been that much discussed, though, is number 4, which is about third and fourth party security risks. Now, it leads us back to the feature that I previously mentioned, that as healthcare service providers usually operate from remote, and additionally their employees, their colleagues, their experts, the system administrators by humans, I understand it, so as humans, let's say, they started working from home officing and from their home environment by using their home networks, which are usually unprotected from industry-driven cyber attack, industry-driven cyber attacks. This is an issue that severely, really severely affects the supply chain in in healthcare. So the trusted vendor scheme, or a collaborative protection profiling scheme or any combination of these. I'm mentioning these two concepts because different industry standards mention different concepts, but at the end of the day, what we need to achieve is a secured supply chain in healthcare from cybersecurity perspective or IT security perspective in general, because this is one of the missing points of which existence in the future will be of crucial benefit for the cybersecurity of healthcare. I believe this is inevitable. This needs to happen. If we don't jump this, or if we don't achieve this, we will get even more trouble than we have now. So next one is a little bit of statistics to you related to the number of breach records and how it was in 2019 and a little bit how it is in 2020, or how it was in 2020 and how will that be most probably in 2021. Interestingly, the number of breach records is decreasing in 2019, but the severity of these incidents per incident is much stronger, and that's due to the fact that a few really large health service providers got affected by the data breaches. For example, one particular breach ended up publishing more data or having more data disclosed than all other data disclosed from all other affected health service providers. So we have less number of breaches, but the amount of data breach is much larger. And this is the trend that we foresee for 2021 as well. Oops, let's go back one. This slide also reflects something similar, and it is related to the breach reports that we actually have information about. The breach types are also interesting. The largest number comes from IT incidents, and the entity type is quite, let's say, obvious as well. It's the healthcare service provider. Where did the breaches occur? Endpoint security has been mentioned by a fellow presenter today. What I would like to draw the attention to is actually the role of securing the emails and also the role of awareness in how to use emails and the role of awareness of what not to click on from non-cyber end user perspective. The second most important issue that comes up is basically network security and server security. And the third one is something completely different. So what we have to understand is the importance of the awareness of the end user on the one side. On the other side, the importance of securing, cyber securing the IT security and IT maintenance supply chain, and to provide this sort of add-on security layer to those sysadmins who work from home due to the COVID situation, home officing issues and trends. Okay. That's also quite interesting. This is for cybersecurity geeks, let's say. The published stolen data by ransomware groups, and this is a chart of how the victims of ransomware attacks are sort of relate to one another. as you may see, when it comes to ransomware, which is quite a typical attack type nowadays, the most affected one is manufacturing and professional services. But healthcare and pharmaceuticals is within the top 10. The cost of data breaches was also mentioned previously, quite rightfully, because I believe I can't exaggerate it anyhow, because it speaks for itself. The number, so the cost, not the number, sorry, the cost of one breached data item is the highest, is like double of anyone coming under that or behind that in the health industry. So if you take cybersecurity from financial perspective, not from human perspective, if you secure your health data, you actually generate a huge cost saving procedure for your organization. This aspect, statistics aspect, is it shows you quite an important issue. It was already mentioned previously, and also it's quite sad, let's say. It's actually the healthcare industry in which the most time is spent without being able to detect a cybersecurity incident within a system, which means, again, I'm repeating myself, it usually takes a year or almost a year. It's actually, I believe, 11 months time to reveal for a specific healthcare system that there is an attack ongoing within the system, which either means data exfiltration or mild service disruption or anything else that may lead to ransomware attacks, data stealing, data disruption, or even some terrorist attacks later on. And again, these go undetected for 11 months on average. So what comes next? Perhaps that's the most important question. Maybe rely on common digital tools. Is there any answer that the EU have already formulated to tackle this? Yes. So the point is that currently there is only one shared database for the technical cybersecurity community that we could use, or we can use successfully to tackle COVID-19 related cybersecurity attacks. And this is the malware information sharing platform, as known as MISP. This is the only one that we can use where data is available for the public. This is an open source community-based platform. And the problem is that at the moment there is no centralized EU-driven, EU-funded, or any other multinational organization-funded database that solely is dedicated to collect and share healthcare-related cybersecurity incident data. This work, the good news is, we usually say that every cloud have their silver lining. The point is that there will be a dedicated EU database built up in the upcoming 1 or 2 years. Interestingly, this is one of the most important benefits of the COVID-19 situation when it comes to cybersecurity, because if COVID hasn't happened, I personally don't believe that such an information sharing database would have been developed that fast. So this is an added value here. What will be available mostly, or hopefully, is medical information, cyber threat related, COVID-19 cyber threat related information, Also, what may lead us to a completely different topic, disinformation related to COVID-19 that we can understand from cybersecurity perspective. Added value may be here if we start using security big data analysis on a massive scale. When I say that, I mean correlation-based modeling and creating prediction models for potentially upcoming cybersecurity incidents. That would be very much of use for the cybersecurity industry, I believe. And this leads us back to the previous speaker, statistics and available data. Which the number of available data that we already consider as big data is of extreme importance. The cybersecurity community uses it quite extensively for building up prediction models. Also, there needs to be an even more detailed and even more, let's say, handy legal framework built up or enhanced in the, let's say, in the European Union. Apologies for the background noise. This will go away in a minute. Yes, because the EU, the European Union, have already started building their or our data and data use related legal framework. Let's start from the Network and Information Security Directive through the GDPR, the General Data Protection Regulation, then the Cybersecurity Act. And then now the EU is building up its organizational structure to tackle cybersecurity issues in general. Just to mention a few, there will be, let's say, a solid collaboration between industry and national administrations and also the central administration of the EU. Through building up the new network of competence centers and the EU SOC network, which is the Security Operations Centers network, which are for monitoring and sharing cybersecurity incident-related information. So basically, I believe that these are the most important issues that we foresee for the upcoming 2 years, and it's quite a bittersweet thing to say, but COVID-19 actually helps a lot to the cybersecurity industry from this perspective, because COVID-19 posed additional problems, trigger these events to happen much quicker than expected previously. So that was all what I wanted to mention. Thank you for listening, and Dana, I think you can take the presentation role from me.
Okay,
so
thank you very
so.
much. Thank you very much for that very interesting presentation that you just gave. It's wonderful to have the other perspective that complement actually the other two. It's interesting how all three speakers coming from completely different backgrounds actually touch on the same types of topics, but from the different perspectives. Okay, I see Malcolm has just left. He wanted actually to speak, so I don't know whether he'll be coming back or not. I was just about to offer him the floor. But okay, let me just continue now with my slides as an introduction to the roundtable. Roundtable is going to take a free-form sort. Annette, you can mute and do your camera for the next 5 minutes, and then I'll bring you all back on, okay? Thank you. It will be a free form, it will be organized discussion. If anyone wants to speak specifically, please just send a message in chat and I will put you on the list to speak. But let me just continue with a little bit more information to start off the roundtable session. I was looking on the internet, and I was looking at securelist.com, and I found there a very interesting article that had their healthcare predictions, and I literally just copied and pasted them in here because I think that this will lead us to a good discussion, because they talk about their concerns for the future within the healthcare industry. So first of all, obviously the dark web to do with medical records will grow. It was talked about the fact that data is a natural resource now. Well, obviously natural resource is worth money, therefore the dark web wants their share and wants to be able to sell information from medical records. Therefore, they have more incentive to try and get these records and to try and breach the data in order to be able to sell it on the dark web. So that's something very important to think of. Another prediction they have is that the access to internal patient information is not just to steal, but they can also modify records. If you have access, you can change things. You can change the dosage that someone has to receive and effectively kill them. You know, it could be targeted like that. That could be an assassination of the future. But obviously, that's very, very dangerous if records can be modified on a personal health point of view. It's not just data being stolen, it's something being changed. That's very, very, very important, that cannot be overlooked. Most countries do not have full digitalization of their medical healthcare systems. However, because of COVID, that has been jump-started, and more countries are starting to fully digitalize their medical services, and therefore the number of attacks will just increase because there's more to attack. There's relatively small amount worldwide that's actually available to attack at the moment, and that will just get bigger and bigger. It was interesting actually, because I'm in Israel, and we're, I think, one of the only countries in the world that's fully digitalized, which is why we have all the vaccines now, because we can give the statistics back to Pfizer on how it's working and things like that, because it's all digitally online. And it was interesting because it was pointed out by the speakers, by Victoria, I think it was, that pointed it out, about the informed consent to do with this, because I certainly didn't allow anyone to digitalize my stuff, but it's just done. That is the way the healthcare works. And what's interesting, here in Israel, there's some discussion as to the fact that no one asked us to be able, for our medical information and for results to be taken from our medical information in order to give information back to Pfizer, for example. Because one of the things that they're saying is that the Prime Minister promised Pfizer data in exchange to having more vaccines and to be able to do it. And so that was the agreement they came to, as well as the payment. Whereas here there's a discussion saying, okay, he's promised that data will be given back to the pharmaceutical companies, but the population never actually agreed to that, never was part of the discussion, was never asked. So that's an actually interesting dilemma there from that point of view as well. Also, there's going to be a growing number of targeted attacks on the pharmaceutical companies conducting the research and the medical research institutes, which will affect the healthcare. And that's important not to discount as well. So far, we've not seen the implanted medical devices like neurostimulators, pacemakers being specifically attacked. However, they're vulnerable. I mean, I know a member of my family has a pacemaker, and she goes and gets her pacemaker checked out twice a year, and they go and they put something on her pacemaker and they talk to each other and they get information. That's just a wireless talking. I very much doubt there's huge security things there. I mean, to the effect that they can't, people with pacemakers in airports and things cannot go through the detection things, and they have to go around the side, just shows how vulnerable these implants are to outside stimulus. Just imagine what would happen if you could affect specific devices. So you could walk past someone and trigger something, and suddenly the pacemaker stops working. That, so far as we're aware, hasn't happened, but that's certainly a big weakness in the future that could happen, and need to start thinking of security of these devices as well. And obviously the ICT is good. It changes, it has the potential to change healthcare for the better. It makes things easier, more convenient, but there's also the flip side of it, that it can also, as we know, open up opportunities for the information and the data it collects to be abused. And one thing that we are trying to do very hard is the IT organizations, when they are producing the new solutions for healthcare, is that they listen to the social sides and the concerns and build in protections at the design stage, and not wait till afterwards and then say, hold on, this is a problem, we're going to have to come up with some solution. So that's important as well. Just a few statistics. The National Health Service in the UK was targeted, as we know, by a ransomware attack. That cost the National Health Service about $100 million. The healthcare industry lost about $25 billion worldwide in 2019 to ransomware attacks. These are huge statistics, okay? And more than 93% of healthcare organizations have experienced a data breach in the past 3 years. That's scary, okay? Because not all data breaches are harmful, but the potential is there to show the amount of data breaches. And if you have something malicious going on there, then you have to be careful. Finally, I would like to show you this. It was just an article in the news that came out a couple of weeks ago. When was it? On the 8th of February, where one of the big IT firms in Israel's had a cyber attack on it. And for example, they have an in into hospitals. Okay, so they produce the systems and stuff, and if they're attacked, then what does that mean about the hospitals that they supply to? So I just wanted to show that this is up and coming, this is happening, it's happening now. It is a real problem that we are facing, and we need to have solutions. We need to look at the healthcare industry the same as the security industry looks at things. We have done work with some security companies, for example, and at some point they won't let us work on our own laptops. They will provide their own laptops to give to us that has no outside, that we're not on Facebook on it and stuff like that. Because we talked about peer-end cybercrime, is the easiest thing is to hack my laptop or hack my telephone, and then that's an in to whatever systems are being used. Security companies are onto this. They have secure laptops where you're only allowed to do your work and nothing else, nothing external. With email, with some security companies with email, they will not use email. They'll certainly not use WhatsApp or anything like that. They will send you something you have to download onto your computer, which will encrypt any email before you send it to them, and then they will uncrypt it at the other end. So the security industry takes cybercrime very, very seriously, and so they should. Unfortunately, the health sector needs to catch up. I mean, I believe that there should be more, the security systems, the security people, the security IT people should be brought in more to the healthcare systems to give them the same level of security that they themselves have perfected. Okay, I now would like to, I'm going to request please that Victoria, Ron and Annette put your cameras on, and we will start the round table session. Does anyone from the audience, first of all, have anything that they would like to start with. Why can I not see the cameras? Oh yes, I can see the cameras. Okay. Is anyone in the audience would like to start a topic? If not, I will start. Give people an opportunity to voice an opinion on this. Tawfiq, I have a note here that you wanted to say something. Tawfiq? Okay, right. Well, I will start something. What do you think is the solution? What do you think will be the easiest solution to try and make the end users, which are the easiest point to attack? What do you think can be done from that point of view to try and discourage the cyber attacks that come in through the users? Annette?
Yes, let me take the floor. Yeah, this is quite an easy shot for me.
Okay.
I strongly believe, and it will also be very, very simple, that kind of training the users to very basic cybersecurity awareness that hasn't been done everywhere yet, let's say, is one of the key issues that you simply cannot look over. So it's extremely important. It's really, really extremely important that every one of us who deal with digital devices should receive very basic cybersecurity awareness training. This kind of capacity building is a little bit looked over. We speak about it a lot because this is like a hot topic, but we don't really see that happening effectively all over the industry. That's one thing. And the other thing is that those kind of email system protecting software devices that are somewhere already implied have to be taken into general use and wide use. So that's one thing, that the users have to be aware of what they are doing. But the second thing is that there should be some software devices and some centrally managed things introduced to the industry that actually help users navigate successfully in that kind of very simple, seemingly very simple environment that is emailing, for example, and using softwares for work as end users. So there needs to be new measures implemented on behalf of security of end users. So I'm trying to explain polarizing somehow, or at least sharing the responsibility of the end user here. You can't expect, and no offense please, a senior nurse being very much engaged in mind with cybersecurity when the nurse's primary role to save lives and to treat patients. So there needs to be those kinds of cybersecurity measures implemented and IT security measures implemented that actually help the behavior or guide the behavior of an end user, in a sense that we don't put additional burdens of these people who are already, let's say, overused during, performing their everyday jobs.
The one thing that springs to mind is you're quite right. We shouldn't expect medical staff to become cybersecurity experts. On the other hand, one thing that I think maybe could be quite easy is to stop them using their own equipment, as to have a specific mobile phone or laptop or whatever it is they happen to use, like the security people, where they're not allowed to do other things. It's dedicated just for their job, and then that would hopefully the software and the stuff that's put on that will not be hit, because then users won't be clicking things they shouldn't click because they would only have access to the system. Possibly that could be something. I don't know whether the healthcare facility will be willing to outlay that amount of money, though, because there's that would cost a lot of money in equipment. Victoria, I can see that you're wanting to say something.
I mean, there's a couple of issues around that, and again, this is just me coming from, you know, the kind of baseline, not being an expert. But one thing that Annette said, which I think was really important, was around training. But it's about quality of training as well. So and training. So every year, I'm glad I don't think I've put my employer on the handout, but because I'm going to be a little bit critical. But every year I've had to do a information governance training, keep up to date. You know, you do a quick test and raising issues about, you know, not using your own email, like those kinds of things. You know, the how to use, where to store information, storing information. But it's not. It's used probably along many. I've seen it used in at least 3 different trusts. You know, it's not tailored to what I'm necessarily actually using the data, the systems that I'm actually doing, and actually some decent, it could be very short training. So for example, where I work, we had a meeting just a couple of weeks ago. I've been there in that particular hospital about 2 years, and I'm probably one of the newer people. And we were talking about where to store some particular information on the database, and we were all doing it differently. And we've all done the same training. We're all putting it in different places. And it's because you just don't think about sitting down and talking about these things. If the training had been a bit consistent and more specific, that might have helped. And the other thing was just in terms of the own device issue, which I do agree with, and I'm fortunate that I do have a work phone, work computer. But when we switched last March, literally overnight when COVID came, and it was like, okay, now do as much as you can at home. I still have to go into the hospital some days, some can't be done there, but I'm not on a ward every day. So go home, everybody, right now. So you have to use so I used my own computer, as we all did, for, you know, a few months until that was able to be delivered. And I think that's the kind of thing where actually they're really trying, you know, it's some of those real world that, yes, the ideal is to get everybody onto devices that are owned by the organization and the organization controls. But one of the other things I've noticed is, so I got a new work phone because before I'd been in an office, so I didn't need a mobile phone, which sounds a bit weird, but I was literally at a desk with a landline. So I only got the mobile phone after, you know, we were all told to work from home after a few months. But I could put anything on. I'm absolutely shocked from having other places I've worked that I can actually realise that I can put whatever I like on the phone, the work phone, provided by the...
So it's not locked in any way?
I mean, no. And, you know, I'm like... I'm quite pleasantly surprised. I mean, but surprised, because a previous organisation I worked in, there was absolutely no way that could happen. So it is just really variable.
So it's down to the setup of the individual medical facilities or the individual health organisations.
Yeah,
so maybe one thing that we need to have is, certainly maybe at a European level, that would be the ideal, is to have a set of guidelines for medical organizations that they have to, like everyone has to have their own mobile phone, where they cannot just add whatever they want. The phone is restricted as to what there should be some software on the phone that you log into it, and you only have access to whatever is preloaded on the phone, which is what you need to use for your work to access certain things. So maybe we need to look at some new legislations, new policy, new recommendations. The problem I have with policies and things like that is that they tend to come after the fact. They come very far down the line, and it would take a long time for this to happen. And so we have each, not even within each borough, for example, We've got multiple countries, multiple boroughs within the countries, multiple health facilities within that, and each one is acting on their own. And so maybe things need to be more centralized. Obviously, being Europe, we should try and do it at a European level. But certainly at a country level, you know, each country maybe should be getting things, but maybe we need best practice on how this needs to be done. And because everyone's working on it at the same time, there is no best practice yet to come out of any one country, I don't think. I may be wrong about that. But yeah, what about?
Yeah, can I address
yes.
these points?
Yes.
Okay, so so a couple of things. The first one, there's a more fundamental issue, which is the recognition of fake news. So you're saying I'm getting an email, I should realize this is not what is written, and I should not click as a the background for that is that you do not recognize it as fake news in a sense. And fake news is not just related to cyber attacks. It's a wider issue. Okay, so whether people have the tools, the awareness, the ability to realize whether what they are shown is reliable or not, I think that's one big issue that needs to be considered. The lockdown in healthcare, I don't think is realistic. In the defense industries you refer to, they don't have access to the web. The physicians we work with have constant use of the web, you know, to pick up new papers, new things, and the open access movement is all against that. So I don't think the answer will come from restrictions. The restrictions will not work. And now for the last point, some comments on the limits of training, you know, the limitations of training. You know, Victoria called it quality training. I think people should have some more humble perspective on what training can do and what training cannot do. One of the things related to that, and was mentioned, training can be done for providing information and giving you instructions in a specific situation. The point is that your life will not get you to that specific situation. You need to have some conceptual understanding of what are the principles behind the training to be able to adapt it to the situations you're in. So whoever is doing this training needs to emphasize conceptual aspects, and these tests that were mentioned that are usually designed to pick up whether you remember. These are memory tests. These are not tests of understanding. So if you want to talk about training in order to push for understanding, that means that the people who develop the training material should be aware of that and should know what to do with that. The people who do the training should be aware of that. If you go into education, you see a difference between what is called formative assessment and summative assessment. Summative assessment are these tests at the end of the course where, you know, we want to know if you remember something, but that does not mean that you actually understand it. The typical feedback you get from students, you know, who've studied up to 2 o'clock in the morning, they went through the test, they even got a good grade, but they forgot everything because they didn't really understand it. They just memorized it. A lot of the training that were mentioned before aims at memorization, and it has, I believe, very low impact in reality. You can teach people through procedures. If their situation is slightly different from the procedure they were taught, they have to come up with a way to handle it. If they don't understand the principles, they will not know how to do that. And there is a pedagogical aspect to that. In the pharma industry, this has to do with good management practices. That has one aspect. And in cyber security or security in general, this is also something that can be treated. The informed consent. You mentioned informed consent.
Yeah.
Believe me, a lot of people sign the informed consent without understanding what they're signing. So whether you signed it or not is...
So in that case, it's not an informed consent, Ron.
Okay.
Informed
So,
consent specifically is
even if they did give you an informed consent, let's say they gave you an informed consent.
Yeah.
Okay. You signed it. You signed it because you wanted the results of your lab test. You signed it.
Yes. Yes.
What they wrote there is that the data will not be used for A, B, C, D. Now we are 3 years later. The sample they have can now be used for E, F, G, H, and they are not asking you anymore. They can do now genetic typing. They couldn't do it before. They wouldn't do it before. Now they can do it in different ways. So even the informed consent is not going to solve the issue. That's why I'm putting this on the table. The issue is really, do they understand what is going on? And there are methods for that. Not very widespread, but there are methods which aim at understanding. So if they want to share the data, there should be some kind of discussion on what it is they are sharing. Part of the trick is to also say what it is they are not sharing. We call it a boundary of meaning. What is acceptable and what is not acceptable. So if you want to do effective training on cybersecurity, you should list what is acceptable and what is not acceptable. And you should train people to understand the difference. And there are things written about that. If people are interested, I would be glad to follow up on it.
It's very interesting that we're talking about training, but training can only go so far. I mean, there are some people that we know are untrainable. You know, that's life. And so there are people that will completely ignore training.
The training in 2021 has to be personalized. It's not one size fits all. And the information needs to be reachable. Some people need the information close, very close. Some remember it and they don't want access. The way it is presented should be personalized. We can do that. In 2021, we can do personalized training, on-the-job training, just-in-time training, not one size fits all. You know, we get everybody. We get people at 10 o'clock and they're out at 11, and here we've done it.
I totally agree, but we will always have that one person that will press the big red button when everyone says do not press the big red button. That is just life, unfortunately, and we're talking about lots and lots and lots of people. So so this brings me into one of the questions that I have on the screen, which is, do the documented policies and training and things like that, do they actually match what is happening in practice? How can you monitor what people are actually doing? Victoria, you say now you're working for a place where they've given you a phone, but it's a completely unlocked phone. You can do whatever you want on it. You can go onto websites and look things, click things, and suddenly you've got malware on your phone, and therefore next time you log in, you're opening up the door.
I mean, Can I just qualify that and say I haven't actually tried so yeah, so some of those things I don't know. What I know is I can put like OneNote on it, which wasn't previously installed. So maybe there are
well, you can install things on it. It's not
maybe
locked.
there are some blocks on there, but I honestly haven't tried going onto anything. But yeah,
I would very much doubt there'd be a block, because if there was, you would go in, you'd put the phone, you'd have to use your NHS username or number,
Yeah.
whatever it is, and then you would only have access to the application. I mean, it wouldn't be open to you. You couldn't just go anywhere, I would assume. But maybe that's something that for IT software industries to work on and create something like that, that can be used and could be downloaded onto technology that's then given to people to take home to connect with. I don't know.
I have had that in previous. Sorry, I'm sorry to jump in.
Yeah.
It's just in the previous organisation I worked in, it was exactly what it was. It was I had to enter. I had a BlackBerry, which probably dates me a little bit, but I had to enter. Work BlackBerries. We had to go through the work network. We could not put anything on there. We could only go to very specific. So it's not that it can't happen. It's just it's not happening where I am now. And it's
so it's not yeah, so it's again each healthcare place on its own, depending also on how much budget they have, because as we know, all this cyber security costs a lot of money, and we're talking about healthcare which is lacking in money. It's always lacking in money. It's completely underfunded, and so they will have to make financial decisions. That's why maybe it shouldn't be up to them. Maybe there should be something above them that is forcing something to happen, or maybe the government will produce something that has to be. I don't know. Anyway, another thing that's important, I think, is that okay, there are cybersecurity incidents and things like that, and this is something that Annette mentioned in her talk, is that sometimes these things can be undetected for long periods of time, if at all. Surely there should be some systems in place that maybe you can't prevent it, but at least lets you know that something has happened, that there has been an unauthorized access, there has been some record that has changed by a user that hasn't got, I don't know, something like that. How easy would that be to fix or to put in, or is this a difficult thing to do?
Actually, it's not a difficult thing to do. It's quite a manageable thing when the necessary financial and human resources are dedicated. We have a couple of sayings, let's say, or proverbs, even in the industry, in the cybersecurity industry. There are two favorites of mine that I'm very happy to share with you. The first is, cybersecurity works well if you don't recognize it when you use your system for the specific purpose that you should be using that for. It definitely needs to work in a way that you don't recognize burdens posed by its existence, especially from healthcare perspective. And the other one is that the vast majority, actually at least 80% of cybersecurity incidents may be handled, or may have been handled, or should be handled in general based on human resources and monthly wages provided to human resources. So in theory, there is no need to impose huge, centralized, very costly cybersecurity measures to reach a basic level of security. Now, this one statement, if someone takes it out from the recording and uses it as one standalone sentence, will not be true. But this will only be true if you understand the context. It's like that by 2021, everything that could be bought from the market, so purchased from the market, and when I say everything, I think about IT security equipment, software and hardware, have been bought, okay, and implied, built in the systems. So we have the necessary hardware and software at the majority of places. We have them installed, okay. The point is that those humans who should be able to use those properly have a lack of cybersecurity skills, because a system administrator is responsible for managing the system and to provide uninterrupted service, let's say. Cybersecurity and security in general is not on his or her primary agenda. So maintenance, we need to understand that maintenance and security are two completely different issues, okay? And what we do now, we expect the maintenance people to provide security as well.
Yeah.
How come? Why do we do that? It's like you would expect me to be a specialized, you know, trained nurse in AR. So I could never do that. I mean, I can look after my kids and my family, but I would never dare to do it in a, you know, specialized environment, because I'm not trained to do that. I'm trained in different other things or other things, let's say. So to put it very simply, the security, so we already have everything that should be used properly. If we can use it properly, then we can have an up and running monitoring system, security monitoring system on our systems, let's say IT systems, and then it gives us a long-term knowledge of what's in our systems and whether those devices function, software and hardware devices, function in a certain way. And if we monitor it long enough, we will immediately be able to detect and understand if something starts working differently. So it's like a differentiation from the basic noise of the system that we understand, okay, and that we have been monitoring on a long term. If we can do that, there's only one more let's say step to take, which is cyber threat intelligence based, or much rather in 2021, applied intelligence based analysis. And that would give us an immediate and clear understanding of what's going on in our systems. Additionally, even just one step further, of that, by now, based on mathematical algorithms and the current development of deep learning and artificial intelligence algorithms, and a certain combination of these would actually enable us to predict cybersecurity threats approaching our systems, and the level of achievable prediction is quite high compared to what we had like 5 years ago, because now we can predict upcoming cybersecurity incidents to more than 70% for the upcoming 4 or 5 weeks in advance. So it's actually, by now, I dare to say that it can be predicted even. And what we have in reality, these attacks, these are much rather not simple attacks, but incident scenarios coexist in our system with us for 11 months undetected. So in reality, we are that far from an ideal situation that you cannot experience in any other industries.
Mm-hmm.
So from cybersecurity perspective, healthcare is in the actually in the most terrible situation. I cannot tell you about any other industries that are so much affected than healthcare. Healthcare is the worst.
There is a parallel in operational risks, which is what is being regulated in financial institutions. There are the Basel agreements, which regulate financial institutions. in the Basel agreements, you have three pillars. You have operational risks, market risks, and credit risks. The operational risks are exactly parallel to what you are describing. And what has happened is that in Italy, for example, there's been a database which aggregates operational risk events from banks, so that there is some kind of common. So up to what they can share, there is something that they can share, things that they cannot share. In operational risks, there have been a lot of things done which seem to be paralleling what you are describing. And we were in a project called Musing, which is multi-industry, which was focused on operational risks in FP or the FP5 or FP6 project. Actually, we had several tools developed in that context. So maybe I'm just reflecting on this. Maybe this parallel can be exploited. Sorry
somehow,
for.
yes. Yeah, no problem. Somehow, yes, but what you are talking about, and no offense, please, absolutely no offense, please, but what you are talking about is simply money.
No. Operational risks are the ATM get hacked, and the money is not transferred through the system. Operational risks.
I understand that, but you are talking about the financial industry, and if there is a loss resulting from cybersecurity incidents, you lose money. Okay, and in the national security, there is a proverb that we usually say in such situations that, has anyone died? No, then let's move on. Okay, in your segment, in healthcare, it doesn't work, because if I attack, a low radiation device and I modify the settings of that, I can easily kill the patient. And then I cannot say anymore that, has anyone been killed? Let's move on, because someone has been killed. That's it. You can't turn it back. So in the financial industry, you can simply print a new box of money. It's that simple at the end of the day from operational perspective. In healthcare, it's not that simple, because if someone has been killed due to a ransomware taking over the control of an oxygen providing or ventilation device, and the patient kills, you can't turn it back. What is really frightening for non-cyber people is the existence or introduction of cyber physical, this concept, when cyber is not only cyber anymore, but it starts having effect in a slowly growing but already existing way in your physical life or over your physical life scenarios. And I believe this is what should be tackled and should be concentrated on in the healthcare industry. And we started, talking about training. Yes, it seems to be a not that important issue. But if you take let's say now prominent or now fashionable attack scenario, you can easily understand that the majority of lethal or potential lethal attacks start 11 months before, let's say, by clicking on a malicious PDF attachment. So it's a very complex life cycle, a very complex supply chain in a pervert way, if I may use this expression. Apologies for that. It's extremely complex, and we need to find ways how we can tackle these very simply. Otherwise, we will start losing patients, and you don't want that, do you?
Thank you. Jivi, you had a question. Do you want to ask it out? If you put your microphone off, put your camera on, you can join in. If not, I'll ask it on your behalf. Okay, Jivi's question was that we're talking how the healthcare industry is losing lots of money through cyber attacks, and how the European countries are trying to protect from cyber attacks in general. And his question is, do we have any statistics on what types of organizations or what countries are organizing these cyber attacks on our European healthcare systems?
Yes, we do. If you wish, or if that helps, we can share that later. There are statistics available, but it leads to another question, which is attribution. I don't think it's the topic of our discussion today, and I also see that the time is running. So attribution is quite difficult in cybersecurity incidents. We usually have special expertise people do attribution, but at the end of the day, the answer is very simple. Yes, statistics is available. But let me ask back, why does it matter?
I'm just asking the question. Jivi, are you online?
Why does it matter who the attacker is?
I don't know, maybe, but no, I was thinking maybe you can block off countries or something. Maybe if it's external countries, you can block off access from all countries, but then you have the VPNs. So you can.
It doesn't work
find your way around.
It doesn't. This. Yeah. Just think about how the internet works. You can't block. So you. I mean, theoretically and technically, you can block, for example, the domain like .hu, which stands for Hungary, but it doesn't work like that. What is more efficient this way is not to concentrate on certain countries, but to concentrate on certain adversaries whom we know, and to block those IPs. Even you can technically do that, even if these are moving IPs, let's say, or flexible IPs, and transferred every 4 hours to another internet domain service provider, which is a country of one of the a specialty of a large country, whom we know quite well. So there are technically there are measures to tackle this issue, but it's quite costly, and it already needs the collaboration of national security entities, governments, and some very significant industry service providers, which also is an existing thing. But I don't believe that we have to discuss it now. I am very happy to give another discussion or webinar or presentation on this, because this is quite, so basically this is one of our specialties. We are quite heavily involved in cyber threat intelligence and applied intelligence. We work with national security organizations. We used to be former national security authorities. So I myself, I have this background. And I was primary representative to Hungarian National Security Authority, anyway, to NATO and EU. So this is an existing issue. Surprise, surprise, this is not widely discussed, but it's discussed among the industry, and there are these collaborations existing. The point is that is always the question of information sharing. If the relevant pieces of information are shared at a relevant or timely manner, then we can tackle these issues in a collaborative way. But there needs to be collaboration in information sharing. If it does not exist, then no success.
Okay, thank you. Ron, during your presentation, you mentioned there was something you wanted to talk about in response to Victoria. You said you'd want to talk about it in the discussion session. Do you remember what that was?
Yeah, so Victoria contrasted the benefit of the patient, let's call him, and the benefit of the family. So there was seemingly there was some tension. You know, maybe these two goals are not aligned. So if you want to understand the quality of the information that this specific device is providing, you cannot do it if you don't explicitly specify the goal of the analysis. So you know, we are coming to the same point from different directions. I cannot say if the information on my watch with GPS is quality information if I'm not explicit as to the objectives, the goals. So in assessing information quality, you first have to make the goal explicit. Then you consider the data that is available. Then you consider the analysis. And part of the story is also the chronology of data and goal. I mean, your data, you collect it, you analyze it. Are you coming up with findings that are temporarily relevant? I mean, if I'm going to give you a location 2 days later, it's not useful for tracking or for certifying that. So there is a methodology that can be applied to clarify these different situations that that Victoria was mentioning. I think that was the point. I'm not sure, but I did have one comment on something you asked before. In Israel, the hospitals are accredited through what is called the Joint Commission International, JCI. I don't know if you have familiarity with that. JCI has added in its assessment guidelines issues related to cybersecurity. So if someone is interested, you can see there is slow progress. You know, it does not require hospitals to become cybersecurity experts, but when the assessment is conducted, these issues do come up. So it is not ignored. Whether it's enough, it usually is never enough. But things are happening in that field. So it's regulated through this JCI organization that is accrediting hospitals.
That's very good news, Ron, to hear that, considering we're part of the system. But it actually highlights a big problem, because everything went online first, and then afterwards there's someone trying to then help with the cybersecurity. And that's exactly the point of what this project, HubIT, is trying to assist with, is that it should be during the actual process of putting all the technology in, the safeguards should be there already. Maybe Israel will become a best practice for the rest of the world, because we are further on than a lot of other countries in implementing the onlineness of medical facilities, and also now the security level is hopefully being added in at a national level, which is excellent. So maybe we can get in the future some best practice, and they can be implemented in other countries across the world. But again, unfortunately, the protection seems to come afterwards. But that's what's worrying.
I think it's the awareness that this issue needs to be looked at.
Yeah.
The point is, you know, you're talking about interfering with the data on drug dispensation in the hospital, and that could kill people. Mm-hmm. So let me bring some news to you. There are mistakes being done which do have an effect on lives of people. So it's not like it's an isolated issue. There are lots of things that are due. You're talking about human error that, and even in this COVID era, you know, we're talking about data. You know, the Ministry of Health in Israel at some point corrected past data, and suddenly numbers shifted, and who knows why, and there was no visibility into why these corrections were done. So irrespective of cyber, which is an important topic, things happen with severe consequences without even considering cyber. So it's
well, this could be internal manipulation.
Yeah, so it's again the underlying concept. You know, everybody has his own glasses. The main thing is the quality of the information. Cyber has an impact, can have an impact, a detrimental impact on the quality of the information. But on the other hand, if cybersecurity works, you don't feel it because it's been prevented and it's not been corrected. It's been prevented. So that's why I put on the center of the three Venn diagrams that Victoria, the quality of the information. That to me is the organizing concept.
Yeah, right. Well, we're coming to near the end. So what I would like from each of you, if possible, is if you could tell me what you believe are the top things that could possibly be done to help protect our healthcare from cyber issues from your perspective, or any top comments that you have that you want to put across. Who would like to go first?
Shall I go first?
That's fine.
Yeah, I mean, obviously I've given what my background is, so I'm really not going to be able to provide any answers, but I'll just come back to that. It is actually what Ron was saying, but also just, you know, speak, you know, involve the people who are the users and be clear who the users are. And just sharing as much information as possible, but that's from a very kind of lay perspective. Thanks.
Okay. Ron? If you were in charge of it all, what would you do?
Yeah. So I believe in that's against the nature of the cybersecurity community. I'm a believer in putting everything under the sun, which means visibility and exposure. I think people sharing experience can have a major impact. Whether the information is shared in a timely manner is another aspect. Best practices, yes, you mentioned best practices. Whether this will be bottom up or top down, I don't really know. Maybe by domains. So maybe healthcare can be yeah, you are dealing with electricity, right?
You noticed.
Yes. Yeah. So maybe by verticals, you know, maybe electricity supply, cyber attacks, electricity supply. What are the best practices there? Healthcare, what are the practices there? Education, you know, thinking about students, they are now spending time on Moodle and Zoom, and they are given exams on these platforms. You can imagine the temptations of fiddling with what's the information that is there. The temptation is huge.
Yes.
You can call it cyber attack or not cyber attack. I don't know what are the official definitions, but you know, it's not students getting into the cupboard of the teacher, pulling the exams and changing the grades. This can be big time. So I think we are in for some exciting times. I think we have to keep our mind open. I think we have to learn from what the experience has been in other disciplines. By the way, operational risks are not on money; they are on threats. If you were attacked and nothing happened, it will not show up in the books. The capital expenditure aspects that the banks need to manage will not show these attacks, and we developed a lot of methods to assess the hidden impact of these attacks on the books, even though they are not reflected in the books. And I think we can learn from different attempts. I think this type of meeting is fantastic. The three perspectives definitely have complementarities, and I've learned a lot. I thank you for the opportunity.
Thank you. Annette?
Let me jump on one thing, what was mentioned by Ron. I believe that the cybersecurity community is likes not sharing information, and this is one of the greatest misconceptions ever. It's actually the end users who always try to minimize any kind of information sharing about incidents that have happened. The cybersecurity community does have its own information sharing ways, platforms, methods, even standardized formats now to share various types and various functionality, cybersecurity and cyber incident information. The point is that we cannot publish these. We are officially not allowed to publish these by legal means, okay? Which is one of, and I also believe with you, Ron, I also agree with you, and I believe in what you are saying as one of the most important issues. If we could come up to the limelight, to the light, and if we could start sharing relevant information, then the whole over-mystification of cybersecurity in general could go away, and we could start handling cybersecurity as a basic utility, mean of utility, because at the end of the day, the functionality of the internet should be utility, basic service providing, and that's it. And not to over mystify it as it is, communicated nowadays. It has been communicated for 15 years like the most mystical thing ever, which is not. It's machine to machine communication. It's like zeros and ones at the end of the day. Nothing else. But it's like it's so miscommunicated that by now it's very, very difficult to explain things in a basic, simple thing. Okay, but it would be really, really advantageous that, especially in healthcare, we could somehow get closer to this very simplified, natural, basic approach of communicating cybersecurity in general. And the second thing, what I would really think to be relevant and useful and beneficial is to take away the cybersecurity burden from the end users, nurses, doctors, and basic human care workers in health, so that they could go back to their original jobs, which is looking after the patients. Because by now they are so much overburdened with related administration and dealing with extra devices that it really takes away their attention in certain situations from patients. So there should be a new balance found in between still caring with what the patient needs in a physical sense and being able to administer those digital devices that are used for improving situations. Because now at certain cases, I think, for example, in ambulance, in Hungary, this is a typical situation that when the HR comes, or the ER comes, the ambulance comes, the experts who come with the car itself have to use several digital devices, and it's 10 minutes to administer a patient. And we see that this is an issue now. Okay, and the third thing, if I may say that, is quite revolutionary, but I believe that e-health would benefit a lot from cyber threat intelligence and applied intelligence purposes, because e-health is the industry that should be supported by the prediction of upcoming attack scenarios. I would love to see that and make it as a basic best practice.
Okay. Thank you very much, Victoria, Ron and Annette. It's been a very interesting discussion, and I think we've all learned a lot because we all came to this with our own views, and now we can hear other people's views, which is very interesting. So thank you very much. Basically, to cut a long story short, we seem to believe that best practices are important. We believe that training was mentioned a lot of the end users, and also that there were financial implications, a lot of financial implications in implementing this huge task of the cybersecurity within healthcare. Also, you mentioned the fact that security people should be involved with intelligence, and also the IT people should be speaking with the social sciences people in order to make sure that safeguards are inbuilt into systems as they go along. So thank you very much. I would like to please ask just a little bits. As you know, this is being recorded. We will send a follow-up email to everyone that registered and attended. We had quite a high level of attendance, which was very good. It showed the quality, actually, of everything and how interesting it was. We need to, so we will send out a link with the a link to this recording so that you can watch it again, or you can send it out to other people if you wish. Also, we'll send out a link to the presentations from our 3 speakers as well. And in addition, as was in the original email that we sent out with the link for this, there's a link for an end questionnaire. Please, please, please just click that link, spend 5 minutes with the end questionnaire and do it, please, because I'll get in a lot of trouble from our project partner who has to write it all up if we do not get that back. So I really would appreciate if you could fill that in, and it's all online, so it's dead easy to do and send back. So thank you very much for attending. Annalie, do you want to say anything as the project coordinating, the project manager of the project?
I just would like to thank you for your very interesting and insightful contribution. It was a true pleasure, and I agree with Dana that as we had a very high number of registrations, I'm sure that this video will have a lot of views. So thanks a lot once again.
Okay, so thank you very much and goodbye. If anyone has any questions or anything, you've got my email address because I sent out the links, and so my email address is on there, so you can contact me if you need anything or any follow-up, or if you would like to be put in touch with one of the speakers directly, that's fine. Quite happy to put you in touch with each other if you have further discussions that you want to have. So I will stop the recording now, and thank you very much, and goodbye.
Bye, Dana. Bye.
Bye. Bye.
Bye.